Hello, everybody. Welcome to this webinar. And we will have a series of webinars on the topic of dysimmune and inflammatory neuropathies. This is the second one. The first one was held last week, and you can follow it if you miss it on the YouTube channel of our European Reference Network. And all the webinars will be available afterwards on this channel. As a first comment regarding the first webinar, which was held by both clinicians and patients together, interaction between Philippe and Jean-Philippe. The aim is also to have a final webinar at the end of March, collecting all the questions from clinicians and patients. So please scan with your mobile or take note of the website, because this will allow you to make questions that will be answered during the last webinar. This will contribute to our series of webinars, and I will leave it for a while, so you are invited to scan with your mobile the QR code, and this is for submitting questions. And it's my pleasure to introduce to you the speaker of this second webinar, which has as a topic the update on the guidelines for Guillain-Barré syndrome. I think we can stop having this slide, and in the meanwhile, so Elizabeth, you can stop, okay? And so we leave the time to Pieter to share his screening. And it's a Pieter to have Professor Pieter van Doorn to deliver this webinar. Pieter van Doorn is a neurologist and clinical neurophysiologist, training and working at the Erasmus Medical Center, University in Rotterdam. And he has been working on the field of Guillain-Barré syndrome, CIDP, and the whole body of inflammatory and dysimmune neuropathies for all his career, giving extreme, exceptional, extraordinary contributions to this field, studying the risk factors, the development, the way of evaluating, and so on. And recently, he had done a great job by leading the task force that produced the first guidelines on Guillain-Barré syndrome, which is a huge task. And also he contributed to deliver the update of the CIDP guidelines. And he also worked a lot on the field of peripheral neuropathy, chronic axonal polyneuropathy causes, and also Pompe disease. So he's the community is very grateful to the great contribution done to science and clinics of peripheral neuropathy to Pieter, who also was in the past president of the Peripheral Nerve Society. And so, Pieter, thank you very much for accepting to give this talk, and you can start when you want. Thank you very much, Pieter.
Well, thank you very much, David, and thank you all for listening to this webcast. David already introduced me. I'm working in Rotterdam in this department, and most of our research is being conducted in this part of this building. And today I would like to talk about the GBS guideline. And so if there is still some time, I would like to discuss a little bit about some recent findings that have been published in the literature since we published the guideline. These are my disclosures. Before I will talk about the guideline about Guillain-Barré syndrome in more general respect, I will shortly talk about the criteria for the diagnosis that has been published before the guideline was being published, and about the randomized controlled clinical trials that have been conducted over the past 20-25 years. This is basically what you can see during the course of Guillain-Barré syndrome. And in about 3/4 of patients, there is initial an infection, clinical signs of an infection. Some of the patients do develop antibodies against gangliosides. That's more important from a scientific point of view. And then there is a rapidly progressive weakness, and by definition, the most severe weakness will be reached within 4 weeks, and the majority of patients already within 2 weeks. And after a plateau phase, there's a recovery phase. And what you can clearly see that some of the patients have lots of weakness, and some other patients have limited weakness. So there are the severe forms of GBS and the milder forms of GBS, and especially the patient with the more severe forms of GBS definitely need a better treatment. The first guidelines for GBS were already published in 1990 by extremely famous neurologists Art Asbury and David Cornblath. And currently, most of us still use the criteria that have been set already in 1990. Then, 20 years later, Jim Savar formulated case definitions that are mainly used for immunization safety data. And Sonja Leonard from our university later published an evidence-based consensus treatment. Finally, we published by the end of 2023 the grade-based, evidence-based international guideline on GBS. And I will devote this talk on this guideline. The diagnostic features of GBS that were already mentioned by Asbury and Cornblath, that are the subacute onset, very often in people who are otherwise in a healthy condition. They develop weakness of the limbs, of arms and legs, and lowered reflexes or an areflexia. And I already talked about the maximum severity that should be reached in principle within 4 weeks. Then there are another list of issues that are quite variable. Different preceding infections, and not all of the patients remember an infection. Many patients have sensory disturbances, but certainly not all of them. And in general, the sensory involvement is relatively minor compared to the weakness. Roughly 60% of patients have cranial nerve involvement. And autonomic dysfunction can be very important during the course of disease, and in some patients even require the use of a pacemaker. Then the treatment. I will talk about the different clinical trials, but it's of extreme importance that there's careful assessments for the patients, and that the patient need to go to an intensive care unit timely, because roughly 20% of GBS patients require artificial respiration despite treating them with immunoglobulin or plasma exchange. So the course of disease is quite variable. I already mentioned that roughly 1/5 to 1/4 of patients require artificial ventilation, and despite treatment, roughly 20% of patients still unable to walk after 6 months. And very important to say that some of the patients already have pain before the onset of GBS, and also fatigue is an important issue after GBS. And I would like to draw attention to the fact that rehabilitation and support is absolutely essential, although all of you will know that no randomized controlled trials have been conducted regarding rehab and support when it comes to patients with Guillain-Barré syndrome. Here you see a couple of pictures, some of our own patients, some of the patients from the internet, and GBS can occur in a very young age and also in elderly people. Some of the patients require ICU admission and artificial ventilation for a couple of days, like this patient, but we also know patients who have been admitted for artificial ventilation to the ICU for about a year. Finally, patients with GBS always will recover, but not all of the patients will recover completely. So the disease is highly variable. It's often severe. There is treatment available, but despite the treatment, there's a variable outcome. And it's absolutely essential that we all need to look for optimal medical treatment and, if possible, for a better treatment with other drugs. This is more or less the spectrum of Guillain-Barré syndrome. It's from a paper from Sonja Leonard, published a couple of years ago. And the majority of patients have motor sensory involvement, and a lesser part have pure motor involvement. It differs a little bit, that percentages around the globe, but this is both motor sensory and motor GBS are considered normal GBS. So it's not very special when a patient only has motor signs. Then there are a couple of GBS variants, call it variants, patients who have only weakness of the legs, but some of these patients start with weakness of the legs and finally have develop weakness of the arms as well. Now, there are some other local variants of GBS, and pure sensory is extremely rare. You should look for other causes of disease when a patient comes with sensory involvement only. Then there is the Miller-Fisher syndrome, the ataxia, areflexion, eye motility disturbances, and a very rare variety, which is bigger stuff, brainstem encephalitis. And it's important to realize that a part of the patients who start with a clinical picture of Miller-Fisher syndrome finally will develop weakness of arms and legs, and that's called the Miller-Fisher Guillain-Barré syndrome overlap. And so the majority of these patients develop symptoms of GBS within the first week after onset of Miller-Fisher syndrome. So it's already one point that we would like to advise that if you do see a Miller-Fisher patient, that you should admit the patient, because the patient can develop full-blown features of Guillain-Barré syndrome, most likely within the first week after onset of Miller-Fisher. So this is a picture you all know, and the annual incidence of GBS around the world is roughly 100,000 patients every year around the globe. There are almost no single features where there is a strong increase in a local population, but are a couple of them, and I would like to draw a little bit of attention to that. For example, there was an outbreak of GBS in Peru 5-6 years ago, 2019. You can clearly see the orange line. And currently, there's also an outbreak in a city called Pune, which is in the neighborhood of Mumbai in India. And in that area, I think almost 120 patients of GBS are currently admitted, and you can imagine that that's an important issue and also gives lots of pressure on ICU facilities, and the local people there are now looking for possible causes, and maybe it could be an infectious agent like Campylobacter that was the agent that was related with the outbreak in Peru, but all of us are waiting for the results. My talk will of course focus on this guideline that was published about a year ago in the European Journal of Neurology and the Journal of Peripheral Nervous System. It was really a Christmas present, I would like to say. I will also draw some attention to randomized controlled clinical studies that can be found at PubMed or clinicaltrials.gov. And I would also like to draw your attention to the worldwide fantastic international GBS outcome study that's led by Bart Jacobs from Erasmus MC, which covers currently 2,000 patients with GBS from a lot of different countries from all continents. around the world, and that serves for lots of information. A lot of information has already been released, but we expected that a lot of information of Guillain-Barré syndrome will be published based on this IGOS study within the next couple of years. So here I listed for you the major randomized controlled trials that have been conducted. The disease was described already more than a century ago by Guillain-Barré, and maybe some years earlier by Landry. And I think this North American plasma exchange study was really a great mind changer. It showed that plasma exchange is an effective treatment in GBS patients unable to walk within the first weeks after onset of weakness. And it's important to mention within a couple of weeks after onset of disease, because it's very likely that in such an acute disease that you should start treatment as early as possible. And that trial already showed that the effect of plasma exchange is larger when you start earlier within the first 2 weeks than starting in week 3 and 4. Now, then the French plasma exchange study also convincingly showed that plasma exchange is effective. And then in 1992, so more than 30 years ago, it was the Dutch trial comparing immunoglobulin, intravenous immunoglobulin with plasma exchange, showed that IVIG and PE are equally effective in patients within the first 2 weeks after onset of disease and unable to walk. So that was a big change. Then we had 2 possible treatments that could be used, plasma exchange or intravenous immunoglobulin. And in many situations, immunoglobulin is more easy to administer and to organize. Now, because a lot of people, and also I believe that GBS is an immune-mediated disorder, it has been tried to study the effect of intravenous methylprednisolone in patients with GBS. And surprisingly, it was shown that IV methylprednisolone is an ineffective treatment in GBS, which is completely different from the effect of steroids, for example, in CIDP. Later on, we did a study in which we treated the patient with IVIG with or without methylprednisolone or placebo, and also that trial showed that there is no additional effect of corticosteroids in GBS. So there was a French study showing that severe patients with GBS improve after 4 or 6 plasma exchanges, and mild patients with GBS can favor of 2 plasma exchanges because they more rapidly run compared to no plasma exchange. A couple of years ago, we published a study, the CID GBS study, in which patients with a poor prognosis, and I will come back to that later, poor prognosis based upon the IGOS score, were randomized for a second dose of immunoglobulin or placebo treatment. So all of the patients received IVIG. If they had a poor prognosis 1 week after starting the first course of IVIG, the patient were randomized for a second course or placebo. And surprisingly, the second course of IVIG given so very quickly after the first course of IVIG, based upon the fact that the patient had a poor prognosis, was not effective. So a second course of IVIG is not better than only 1 course of IVIG in patients with a poor prognosis, and we also found more severe adverse events. Then there is another study that has been published after the publication of the GBS trials, the JET-GBS study that investigated the effect of eculizumab, and I will come back to that study later. So lots of studies, and fortunately, there are some new studies being published and it's pretty sure that a couple of other studies will be published within the next couple of months or years with new treatments for patients with Guillain-Barré syndrome. So there are a couple of reasons that an evidence-based guideline is important. First, because the diagnosis can be difficult, and we believe that a good guideline enables to make a proper diagnosis rapidly in the course of disease, and we really think that it's very essential to treat patients in principle as early as possible. It also avoids to make misdiagnosis, we hope so. And of course, treatment needs to be adequate. The trial advises when to start treatment, what regimen, and when not to start a specific treatment all based upon evidence. So this is the group of 21 persons who all contributed largely to the EAN-PNS guideline on the diagnosis and treatment of GBS. And I would especially like to acknowledge the two co-chairs, Pieter van den Berg and Rob Hedden, who did an incredible lot of work, but also the other panelists, expert neurologists, did a lot of work. And I would like to acknowledge as well Bert Arvo and Patrick van Krunkelsven, who were the methodologists when we developed the guideline, and Patricia Blomqvist, who was a patient representative who gave us important information on the PICOs that we developed. So I already shortly mentioned that this GBS guideline was based upon the grade system. And what is the grade system? I will touch it very shortly. What is a common way of doing is in not only in grade, but in also searches on the internet or whatever, you formulate a PICO, population intervention comparison outcome. Then we selected the most important outcomes, was searched for the data, and evidence tables were made. And then, I think that's very important, the quality of the evidence is rated. So, for example, if there is a large risk of bias, or there is a publication bias or inconsistency in the results, then the quality is graded down. On the other hand, if there is a large effect, or for example, a dose-response effect in the study, then it's the quality is graded up. Then the overall grade quality of evidence will be made, and then it will consider whether specific information as high quality, moderate quality, low, very low quality. And then it was discussed within the panel, and I'm very glad to say that we rather easily reached a consensus about all of the PICOs, and then we formulated recommendations for or against, or strong or weak. This is again the course of disease in GBS. Here this is healthy and this is a paralysis. And already during the initial course of disease, there are multiple questions, and these are questions that can partially be answered with the guideline. For example, this is if you encounter a patient with rapidly progressive weakness, there are multiple questions on the diagnosis and what to do. For example, is it GBS? Is it indicated to ask about infections, because a lot of other diseases also can have preceding infections? To ask about vaccinations. Is it useful to conduct an EMG or to do a lumbar puncture? Maybe to do ultrasound investigations or making an MRI to look for autoantibodies? And then about the prognosis, what to do if you admit a patient at an emergency unit, and if you can predict that there is a high chance that a particular patient requires ICU admission, then maybe it's better to transfer the patient immediately to an ICU compared to a general ward. And there are prognostic models now. So what are the most effective treatments? When to start treatment? Is it useful to start treatment in patients who are only very mildly affected, or in patients who already have progressive weakness for 3 or 4 weeks? Treatment of pain is an important issue, very difficult. Not a lot of evidence, I can already mention. Is it useful to give retreatment? I already indicated that a second course of IVIG is not useful in patients who have a poor prognosis in the initial phase of disease. And how about treatment of fatigue in patients who recovered relatively well from GBS but who still suffer from fatigue? Is there evidence or not? And then I already mentioned that there's not much evidence, but all of us realize, and I will show a slide on that psychological support is very important for the patient, but also for their relative. And you can imagine that if you admit a GBS patient, an intensive care unit, a patient who is on the respirator, who can't move his arms and legs, but otherwise is in a completely healthy state of life, and if that particular patient has severe pain, there should be attention for that, and there should be psychological support if possible. So physiotherapy and rehab is also of great importance. We all think, despite the fact that there is no real good evidence-based assessment. So we finally constructed 14 PICOs, and I will touch them. One is about the antecedent events, CSF examination, antibodies, electrodiagnosis, EMG, ultrasound, MRI. But it's possible to predict which patients who is initially diagnosed with GBS finally will turn out to have acute onset CIDP. I will shortly talk about the prognosis and then about the treatments I already mentioned. Monitoring ICU admission, I've already mentioned that is largely based upon good clinical practice. So not so very much evidence, but a lot of GPP evidence, and then the treatment of pain and fatigue. If possible, we made a great summary of findings and the recommendations I just mentioned for or against, and a strong or weak recommendation. If it comes to non-trial related issues, we made evidence tables and we formulated good practice points. And finally, I would like to draw attention to the 3 flowcharts that are included in the GBS guideline, and we very much hope, and I will show the flowcharts, that these will help to translate evidence into clinical practice. Well, the diagnosis, is it useful to ask about antecedent events? And we advised to ask about antecedent events to support the diagnosis, especially when there is clinical uncertainty. Strongest evidence for diarrhea, respiratory infections, and fever. After some of the vaccinations, there seemed to be a very small increased risk of developing GBS, but there is we believe that there is a lot of benefits of the vaccination, that this far outweigh the risk of developing GBS. This is the infections. These are results from the IGOS study already mentioned, study by Sir Leonard again, and the most frequent occurring event is Campylobacter. Mycoplasma is also an important one, and in some of the patients, they have dual infections. So not only, for example, Campylobacter, but also Mycoplasma. And maybe that was in that particular patient a reason or a trigger to develop GBS. So the question is whether you should perform a lumbar puncture. For example, in a patient 3 days after onset of weakness, and if this CSF protein was normal, so lower than 0.45. And I would like to ask you, what do you think? Would it exclude GBS or make GBS very unlikely? or is it quite common? Or is it diagnostic for GBS? Well, in fact, it's quite common that you find a normal CSF protein in the first few days after onset of GBS. So it's advised to do a lumbar puncture, but especially when there's no alternative diagnosis suspected, and especially if you want to rule out a kind of infection, if you would like to look for an increased numbers of cells. And I would like to draw attention again for the fact that the normal protein in the first week of onset does not exclude GBS. This is what you can see with the percentage of patients and the protein. If you do a lumbar puncture in the first 3 days after onset of weakness, then half of the patients have an increased protein. And if you do the lumbar puncture in the second week, almost 90% of patients have an increased protein. If you do a lumbar puncture and you find more than 50 cells, that should raise suspicion for an alternative diagnosis. If you do have a patient with 60 cells, does that exclude GBS? Or makes it unlikely? It's quite uncommon in GBS, or is it diagnostic? And of course, the answer is that it's unlikely for GBS, but it does not exclude the diagnosis. That's shown in this patient. This was one of our patients, a previously healthy female, 25 years old. She had abdominal back pain and thereafter rapidly progressive weakness and paresthesias in the legs. When we admitted her at the emergency unit, we thought this is a patient we can possibly include in a CID-GBS study. Bifacial weakness, weakness in arms and legs, sensory disturbances, areflexia, and then we performed a lumbar puncture, and surprisingly, she had 130 cells and an increased protein, but this was the reason for not including her in the CID-GBS trial. And we, of course, thought about another diagnosis, and what diagnosis could you, for example, consider? We especially considered hematological malignancies, HIV, Lyme, sarcoids, and maybe polio. And we did all kinds of investigations and nothing turned out to be positive. EMG was helpful. She had low CMAPs and she had a block in the ulnar nerve. And if you look to the sensory nerves, it can be seen that there are low sensory potentials, but the sural nerve is spared. And sural nerve sparing is very much compatible, not completely diagnostic, but certainly compatible with GBS. Now, in the meantime, the patient was already treated with immunoglobulin, but she came completely paralytic, and she was on the respirator for a prolonged period of time. No central nervous system abnormalities, and we feared a lot. And then she starts improving. That's her now. She comes to the outpatient clinic. The only residual sign she has that she has still a little bit fixation of the pupils. Otherwise, she's completely normal. And if she had not have cells in the CSF, you might have considered an autoimmune nodopathy. But this patient had cells. We considered a lot, and we think it's still GBS, but it is a very special form of GBS. And I would like to draw your attention to this publication, also based upon results of the IGOS study. And if you look to the horizontal axis, then you can easily see that the majority of patients with GBS have less than 5 cells. But some of the patients who otherwise have GBS have a higher number of cells. But if you find it, you should especially look for a large number of other abnormalities. Is it helpful to make an EMG? Yes, we think it is. It's good. to support the early diagnosis of GBS, especially when you're in doubt. And we also stated that subtype classification, AIDP or AMAN, is currently not useful for management of GBS. It is useful in case you want to look for the pathogenesis, immunological aspects, etc. But it's not useful currently for management issues because all of the patients currently still receive the same treatment, but maybe that can change in the next coming years. There's a high sensitivity for motor nerve conduction velocities consistent with polyneuropathy. And I already mentioned sural sparing and also distal CMAP duration prolongation is important. I would like to draw attention to the fact that a normal EMG in the first days of GBS does not exclude the diagnosis, but makes it less likely. Is antibody testing useful? Now, it's not useful from a clinical point of view unless patients have Guillain-Barré syndrome, because the majority of these patients have antibodies against GQ1B. And over the past years, it became clear that if patients who are considered to have GBS, who develop extremely poor condition with a paralysis, maybe they start with ataxia, or when they have a couple of relapses and don't do well after reinstitution of immunoglobulin plasma exchange, that in these patients, antibodies against neuroperinodal antigens can really be helpful and should be considered. And I realize that not all of you will have easy access to the antibody studies, but there are a couple of centers also within Europe who can test it for you. We're lucky we can test it in Rotterdam, but there are many other centers, or in France or in Barcelona, or for example, in Oxford, who can test for those antibodies. I would like to draw your attention to this great paper by the Würzburg group of Catherine Doppler and Louise Appelshäuser, showing a very severely patient who was thought to have GBS, but had antibodies against neurofacin, and the patient was treated with rituximab and later on improved. So antibody testing, some patients can be useful. It is believed that currently there is no additive value of MRI or ultrasound as a routine add-on test for typical GBS. However, especially MRI, of course, should be conducted in patients with a paraparesis, and ultrasound can be considered in patients also with a very atypical presentation. Well, we have made 3 flowcharts already mentioned about that. And the first is about the diagnosis and classification of GBS. And I will shortly discuss this in the next slides. The diagnostic criteria, you can easily find it in the guideline itself. Progressive weakness of arms and legs, absent or decreased tendon reflexes in the affected limbs, and progressive worsening less than 4 weeks. And we all realize that if you admit a patient, that you often don't know how long the progression will continue. But if you see patient later on during the course of disease, and if it's exceeding 4 weeks, it's very unlikely that's GBS. Most patients have a relative symmetry of weakness. Many patients have pain. Cranial nerve involvement is important. I already mentioned CSF protein and the EMG. So if patients have clear asymmetric weakness, or when there is a severe respiratory dysfunction with mild limb weakness and some other conditions, it's less likely, but not excluded, that's GBS. If there's only worsening during the first 24 hours, and then it's stable, it can still be seen in GBS, but it makes it less likely. I already shortly discussed about the GBS variants and the Guillain-Barré syndrome, the Bickerstaff brainstem encephalitis, and more information about this is in the guideline. So if you follow the flowchart, then it's possible to diagnose in the majority of patients with motor sensory or motor GBS. the GBS variants and Wheeler-Fisher syndrome spectrum, and be aware again for the fact that some of the patients with GBS develop mostly within the first week after onset, and also weakness in the limbs like patients with GBS. So it's a Wheeler-Fisher GBS overlap syndrome. And a proportion of these patients still require artificial ventilation. So there is this is the flow chart, and there is also another category that is suspicion of acute onset CIDP. We'll come to that a little bit later. So this is GBS with treatment-related clinical fluctuations, CIDP, and the acute onset CIDP. It's more likely that the patient who was diagnosed with GBS has acute onset CIDP if there are 3 or more treatment-related fluctuations. And there are also some other points that can be relevant. But it's important to realize that the definite diagnosis of acute onset CIDP cannot be confirmed unless further worsening after 2 months. Well, GBS is still a severe disease in many patients. It's of great importance to regular assess weakness, swallowing, assess the vital capacity, ask for pain. There are prognostic models that can be helpful to predict whether patients require artificial ventilation. It's important to avoid, if possible, emergency intubation. And it's important to realize that time is nerve, and especially in severely affected patients, then treat as soon as possible. Then I would like to talk about GBS prognosis and treatment. Yes, it's suggested to assess the risk of poor outcome. There are a couple of factors that are related with poor outcome: IH, diarrhea, severe weakness. And the risk can be quantified using the modified Erasmus GBS outcome score, EGOS. For example, in this patient, this was a 60-year-old patient, onset of weakness 5 days ago, diarrhea, MRC sum score 50 out of 60. Patient had an EGOS score of 6, and if you count then you can easily, this is the EGOS score, you can figure out what is the predicted probability to be unable to walk after 4 weeks, 3 months, or 6 months. Helpful. So what is the worst prognostic factor for a good prognosis? So it's a poor factor if a patient had it. And the worst factor is severe GBS in case of a low MRC sum score. That's more important than diarrhea or age. It's also possible to use the modified Erasmus respiratory insufficiency score, EGOS, and using these individual factors, it can be predicted what the chance is to require artificial ventilation. I will not go into detail. You can have a look at the website or in the publications to find additional information. Risk of poor outcome, higher age, diarrhea, high score on GBS disability scale, higher risk requiring artificial ventilation, rapid onset of weakness, verbal palsy, weakness of neck flexion, and weakness of the hip flexion. You can also go to this website to find these assessment scales, predicting scales. It would be very helpful, very much helpful when there are good biomarkers for GBS, both for the diagnostic purposes and for the prognosis. And I would like to draw a little bit attention on a recent publication about the prognostic value of serum NFL that has been investigated in the patient group of the CIDP study by Sander van Tilburg. What you can see here, this is the time after onset of weakness. This is the neurofilament level, high-low, that there is increase within the first couple of days, and then it comes down. There's a clear relation with neurophysiological parameters, NFL height, and what you can see in excitable nerves or axonal degeneration is especially related to higher levels of neurofilament. This is the GBS disability score, and this is very severe. This is very mild, but you can easily see that patients with a severe GBS have higher levels of neurofilaments. So that is also a prognostic value because the patient with the lowest neurofilament levels at week 2 had the best prognosis for recovery, and the patient with the highest level had the worst prognosis. So that's an important issue, and likely this kind of factors will be included in new prognostic modelings. I already mentioned it, it's important to carefully look at patients with GBS for the prognosis and to assess whether the patient requires admission at an ICU. This is a complicated figure that's also published in the guideline, but basically it says that do risk assessments and decision making at admission. High-risk patients consider directly admission at an ICU, otherwise careful monitoring and treatment, and hopefully the patient can return to the general ward after some period of time. So please have a look if you're interested in that figure 2 in the guideline. Immune treatments. What treatments were used already 6 years ago? And then you can see that was an investigation based on the IGOS database, again by Christine Verboon. But you can see from different countries around the world that the majority of patients were yet treated with immunoglobulin. Some of them received plasma exchange. There's still patients treated with corticosteroids. And I would like to draw the attention that there is not a reason treating patients with corticosteroids. And if you give a little bit of low corticosteroids, it even can worsen the clinical condition of patients with GBS. So don't do it. These are the proven effective treatments that have been published. Yes, immunoglobulin is a proven effective, strongly recommended to start within the first 2 weeks after onset of weakness, patients unable to walk. A 5-day regimen, 0.4 gram per kilogram is recommended, or plasma exchange, also strongly recommended, effective treatment, 4 or 5 exchanges in patients unable to walk within the first 4 weeks and preferentially within the first 2 weeks after onset of weakness. And in mildly affected patients, two plasma changes seem to do better compared to no plasma change. And because immunoglobulin and plasma change seem to be more or less equal, can also be considered to treat mildly affected patients with IVIG. In principle, there's no preference for one of these treatments, but we all realize that there are some favors of IVIG when it comes to a practical point of view. So what do you know about immune treatment for GBS? What are proven effective treatments for patients of GBS? Able to walk unaided, so mildly affected within the first 2 weeks after onset. There's been shown for plasma change, and it's likely that the same holds true for immunoglobulin, but has not been investigated in a clinical study. This is the third table in the guideline, and these are the first 2 weeks after onset that are week 2 and 4. I will come back to this table, the green table, what you should do according to the guideline. So if the patient is still within the first 2 weeks of onset of weakness, unable to walk, or still able to walk and rapidly deteriorating, then it's advised to start with immunoglobulin or plasma exchange in the dosages I just mentioned. Patient is still able to walk, it can be considered to give 2 plasma changes or a good practice point immunoglobulins. However, if the patient is already in week 2 or 4 and still able to walk, so mildly disabled, then it's very much unlikely that treatment is still effective. So it's not advised to treat the particular patient with IVIG or PE. If the patient is unable to walk, and especially if there are also swallowing difficulties or autonomic issues, then it's advised to start with PE or good clinical practice point because it had not been investigated for IVIG with immunoglobulins. No corticosteroids are not indicated in GBS. Multiple trials have been conducted, so please don't use it in GBS. Combination of treatments, combination of PE and immunoglobulin has been compared to PE alone, is not better. IVIG and corticosteroids compared to IVIG is not better. Repeating IVIG in patients with a poor prognosis is not better and gives more side effects. So there's currently no positive recommendation of any other therapy. So this is a flowchart that's currently not in the guideline. It's very practical. I made it after the publication. So if there is improvement or stabilization followed by deterioration, then it's likely a treatment-related fluctuation. Then repeat the same treatments. If there is a poor prognosis a week after onset of GBS, don't repeat immunoglobulins. If there is a further deterioration, if there is no doubt about the diagnosis, then there's currently no evidence that you should switch for another treatment. However, you should definitely consider an autoimmune nodopathy. You can determine the antibodies, and if these antibodies are positive or the likelihood is already very high, then you might treat the patient with rituximab, which is again a good practice point. Treatment of pain, very difficult. There's not so much information. It's useful to ask for it, especially in patients who are paralyzed on the respirator. Try to treat the pain and make a distinction between neuropathic and noroceptive pain. And basically, treatment of pain should be the same like in other neuropathies, and there are guidelines for that. Fatigue is an issue already mentioned. Can be an important issue even if patients have been recovered very well otherwise. And a small trial showed that amantadine is likely not effective in GBS, and there are no other systematic drugs available. Maybe exercise, if possible, is helpful, and it seems to be that it's not a wrong way of doing it. There's no harm. Now, there are no trials, almost no real good information about physiotherapy, speech, swallowing, occupational therapy, other forms of rehabilitation. But all of us, and I presume all of you, will recognize the importance of physiotherapy and rehabilitation treatments already during hospital admission and later on during the course of disease. And it's, I would like to draw attention again for the psycho-emotional effect of patients and their caregivers, and that really requires attention. This is the guideline. I know that time is almost on. I would like to show you a couple of very briefly, a couple of slides if possible, Davide.
Yes, go ahead.
Thank you. The new treatment.
And if people has questions, please do it through the Q&A chat box, or they will be allowed in person afterwards. So go ahead, Peter, please.
Thank you. I'll be shortly. There are a couple of new treatments that are really targeted based on the immunopathogenesis. So that's considering and related to antibody production in patients with GBS and complement activation. There are lots of information. I would like to especially draw attention to the fantastic experiments that have been conducted in the group of Hugh Willison in Glasgow. Lots of evidence that complement activation must play a role in GBS, at least in animal models, and very likely also in humans. It has been investigated already many years ago. So there are a couple of trials now that have been done. Eculizumab, a C5 blocker, and Annexion, the ANX005 in patients with GBS. This is a graph I made myself, and I realized it's likely not complete. A couple of interesting new studies: small volume plasma exchange, imlifidase, which cleaves IgG very rapidly, open study, not yet published. Eculizumab study, C5 inhibitor, and the Annexon study targeting C1q that has not been published yet. Very shortly, this is a small volume plasma exchange when realizing that the majority of patients who will get GBS are living in a less rich area in the world. This is a very cheap treatment. Only a phase 2 study has been done, just drawing blood, hanging up, removing the plasma, reinfusing the red blood cells and saline or albumin. That seems to be safe, and hopefully an RCT will be conducted now. Fantastic study from Badrul Islam in Bangladesh. This is the eculizumab study in GBS. There was a small study that did not meet the primary endpoint criteria, but only one of the secondary endpoints was positive, and that was the ability to run after a period of time. That was published in Lancet Neurology. And then a bigger phase 3 trial was published, which in the Journal of Peripheral Nervous System, and that study showed that there was no difference in primary or any of the secondary outcome measures when using eculizumab when comparing it to placebo. Maybe because it was started relatively late, but that's just a suggestion, and maybe it can be harmful to give a relatively long suppression of complement, but it are just thoughts. The importance is that a small trial is positive and that you always should wait for a proper RCT. HANSA study, a drug that rapidly cleaves IgG. Only 30 patients have been treated in an open study, and the results are promising. The data need to be published, and the data will be compared with data from the IGOS database, and hopefully this study will continue in a proper phase 3 trial. Then the other trial I would like to draw attention to, that is the study conducted in Bangladesh and the Philippines. It's a placebo-controlled trial, and I show the results of the 30 milligram per kilogram. And this study showed in reasonable and high numbers of patients, 241 patients were randomized, and that there is a clear improvement in patients who received the drug compared to placebo. So green is better, and red are the severely disabled GBS patients. So the results need to be awaited, but it seems to be very promising. Some of the results, both of the Annexon trial I just showed and the HANSA trial, will be compared with results from the IGOS cohort. So these are the results of a trial. Then more or less the same patients are filtered from the complete IGOS cohort, and those can be compared on several ways, and hopefully it can be helpful to select drugs for phase 3 treatment. So what were the most relevant issues? That we have a GBS guideline. 14 PICOs have been more or less answered, the recommendations, and I hope that you will find the flowcharts helpful. And I think it's a very exciting time for GBS because now there are really new treatments coming on, and treatments who are likely or maybe are effective and will be tested in the near future. So that's really a big achievement. I would like to thank again the task force members, I would like to thank the organizations who sponsored making the GBS guideline. And of course, I would like to thank you for listening, and the European reference work who do so extremely important work and give the opportunity to discuss this guideline this afternoon. And finally, I would like to thank our group in Rotterdam, which we'd like to do a little bit sailing now and then as well. Thank you so much for listening.
Thank you very much, Peter. This was a fantastic talk, very effective, quite clear, and really helpful for attendance. And so I invite people to make questions. I already see two. One is an attendant that probably is a patient, had a dramatic experience of being completely locked in without being able to move anything but reactive pupil, so probably without eye movement. And he was perfectly conscious. He's asking how to make doctors aware that such a person can understand everything, being completely paralyzed. And that's a very difficult question because
it's a typical ICU question, because we must try to convince the anesthesiologist and etc. at the ICU to be careful and not laughing the whole time aside of the patient, because the majority of the other patients who are admitted at an ICU do have severe other issues or brain involvement, and it's an important issue. And it's also important to ask for pain and really to try any kinds of let's say communication with the patient, for example, nodding or moving an eye if one time is yes, twice is no, etc. It's a very important point you raise.
Okay, thank you, Peter. There were some people experiencing problems with the internet, but I'm sure that the webinar will be uploaded on the YouTube, so you can follow afterwards. And another question is how we can differentiate between GBS and acute CIDP, especially at PT with DM. I don't understand what does it mean, but you have already mentioned a little bit.
Yeah, it's a good point. One of the PICOs was about that, and especially in patients who have treatment-related fluctuations, if you have 3 or more, then it's very much likely that it will be CIDP, acute onset CIDP. And an important issue here is that as soon as you really consider, are convinced that it is CIDP, that you can also treat the patient with corticosteroids, which you should not do in GBS. There are some issues. I discussed a couple of the triggers to think about acute onset CIDP. They're also mentioned in the guideline as well.
Okay, now, there is another question, a practical one. Which is the best time, in your opinion, to perform nerve conduction studies, also taking into account balancing the different exam you can have, alternate diagnosis, and also resource limitation?
Yeah, that's also a good question. The highest chance to find abnormalities if you do it after 2 weeks, but the most clinically relevant issue is if you doubt about the diagnosis, then you should do it as early as possible. And as soon as you find a polyneuropathy, then the chance that GBS is higher. As soon as you find clear demyelination, then the chance that it is GBS is pretty high. So I should do it early, relatively early, despite the fact that the sensitivity is lower compared when you do it a little bit later.
Okay, Stefano Previtali is going to make a question from direct voice. So Stefano, you can unmute yourself. And you're not unmuted. Maybe Elizabeth, you need to unmute him. Okay. Oh, for a while you were unmuted.
Stefano, you can unmute yourself.
It seems. So let's see in the way. Stefano, keep on trying. If we have other questions, we will go through them. And Ana Pilar Ramos is thanking for the lecture and asking if a GBS patient who received IVIG has a deterioration, do you recommend the plasma exchange? Yes, what about the problem of removing the remaining IVIG? Yeah.
Yeah, there is no trial showing that you should start a second treatment if there is more or less a failure after immunoglobulin. There is not good information that you should start with plasma exchange. I would say if the patient does very poorly after immunoglobulin or plasma exchange, that you should look for the antibodies against nodal paranodal antigens. And switching to another treatment, I know that a lot of doctors do it because you would like to do it, you like to do something, but the rationale is not that large. It's not a failure. And of course, if you do plasma exchange shortly after immunoglobulin, then you waste the immunoglobulin. So that's not really the way I should like to go.
Yeah, difficult to resist for patients deteriorating, but the recommendations are quite clear. Another question is, for obese patients with more than 120 kilograms, what is the best IVIG or plasma exchange indication?
I don't know. And let's say determining the dosage in extremely heavy patients also an issue, not only GBS, but also in CIDP. And whether you should still give 2 grams a kilogram, we currently do it. But trials in CIDP have shown that you can infuse IVIG to a maximum of roughly 100 grams a day.
So, but if you have patient obese, would you follow the 2 gram per kilo or a little bit lower?
But we limit it somewhere, but there's no real evidence. But for us, it's never a reason to switch to plasma exchange. So in principle, we still give 2 grams per kilogram.
Okay, thank you.
But that's what we do. That's not necessarily the best way.
Yeah, yeah. Oh, I don't see any further question. I remember that you were discussing the development of an app for the GBS guidelines. Are you working on it?
Currently not, but Rich Lewis and Jeff Allen and others, and Rob Hedden as well, and others are working on an app for CIDP.
For CIDP.
If it turns out to be good, there should be an app.
Yeah.
And we'd love to do it. You need some money for it, and yeah, it would be great. If anybody who's listening this afternoon has a good idea how should that be developed, or can help, or has a good advice, we would love to hear it.
Okay, okay. I think time was enough. It was great. Thank you so much, Peter. This was very effective. I'm sure that people appreciated it. There is a Kevin Chauhan who is a mobile app developer. So
please send us an email.
Contact Peter directly.
Yes, please. I would like to thank you again, and I'm very sorry for using a little bit too much time.
No, it was very appreciated. I'm sure that everybody was happy of this, and we have also some time for discussion. You can follow, remember, on the website, on the YouTube channel afterwards if you're not able to follow everything. And please follow also the next webinars almost every Thursday at 4 a.m. Central European Time, p.m. Central European Time. We will have a webinar until the end of March. So thank you once more, Peter, and all the attendants, and see you next week and the following weeks. Thank you so much.
Thank you so much.
Thank you very much. Goodbye.
Bye-bye, everybody. Bye-bye.